Uh, Stephen Markowitz. I'm an occupational medicine physician, epidemiologist. I was the last resident to train under Dr. Selikoff at Mount Sinai in the mid-1980s. I was in the faculty at Sinai for 14 years. I left to join the City University of New York in 1998, where I've been ever since. And I run the largest occupational medicine screening program in a single industry in the country, in the nuclear weapons industry, for people who built our nuclear bombs, including for the past 20 years, screening for lung cancer. It's the largest occupational lung cancer screening program in the country. So let me share my screen here. So what I'm going to talk about is a disease that last year caused over 100,000 deaths. This year will cause well over 100,000 deaths. And the shame of it all is that we have in hand a medical intervention that we can use to interrupt, to detect this disease early and keep people from dying from the disease. I know you think perhaps I'm talking about COVID and the vaccine. We have vaccines in hand that could prevent a lot of deaths, which we have, which unfortunately many people either aren't using or don't have access to. But actually, I'm talking about lung cancer because this essentially the same condition applies. Over 100,000 people will have lung cancer. It's estimated, for instance, in 2021 that 132,000 people in the US will die from lung cancer. And that applies to both men and women. It's the leading cancer in men and women by far. In men, 22% of all cancer deaths. In women, 22% of all lung cancer deaths. So it's far more common as a cause of death in women than, say, breast cancer, which is number 2, or prostate cancer, which is number 2 in men. And as Linda pointed out yesterday, I think also Dick Lemon this morning mentioned, actually, when you talk about the asbestos cancers, which Jackie reviewed, the number 1 asbestos cancer is lung cancer. You know, we hear a lot about mesothelioma because it's a terrible disease and because asbestos is virtually the only known cause. And obviously there are other causes of lung cancer, but actually when you count the number of people who've been exposed to asbestos in the past and develop lung cancer, it very considerably outweighs the number of people with mesothelioma. So we have about 3,000 cases of mesothelioma each year in the US, and we have anywhere from 6,000 to 30,000 cases of lung cancer due to asbestos, depending on what multiplier you use. So it's an enormous problem. Fortunately, we have a mechanism to detect lung cancer early. And Jackie mentioned this. It is, in fact, the only asbestos cancer that we can detect early at this point. And it is through a low-dose CT scan. And let me explain what a low-dose CT scan is. Low dose means it's a very low dose of radiation, meaning that we can do it every year without harming people. And it's a regular chest CT scan. It takes about 30 seconds. I mean, it takes you longer to either take off your shirt or change their shirt, what you're wearing, than it does on the CT scanner itself to get the scan. So it's a very easy, low risk scan. It involves no injections and it's really no obstacles to, in terms of the procedure to receive a low dose CT scan. Now, there is some good news here. And the good news this past year is that the US Preventive Services Task Force, which Jackie introduced a few minutes ago, changed its criteria for eligibility. This is important because when the US Preventive Services Task Force says that a certain group is eligible for screening, that means that private insurance, Medicaid, and Medicare have to cover it, okay, for free or for minimal copay. Okay, so we're talking about the group that is now eligible, or it's been eligible since 2013. But the task force has changed and broadened the eligibility criteria so that many more people are now or will be soon eligible for CT scanning. Now, the way the US Preventive Services Task Force addresses this, they always focus on age and smoking because that's where the most research has been done. They like to base their studies and their recommendations on as much research as they can. And what they did this year is lower the eligibility age from 55 to 50. So now people starting at 50 are eligible. They lowered the amount of history of cigarette smoking that you needed to have. It used to be 30 pack years. That's a pack a day for 30 years, or the equivalent. It could be 2 packs a day for 15 years. That's 30 pack years. And they lowered it to 20. So they lowered the age limit to 50, and they lowered the pack years to 20. And to be eligible, you have to have quit less than 15 years ago, because the idea is that lung cancer risk diminishes over time. And so after 15 years, it's less than it is less than 15 years. That's the official group eligible. Let me just give you my opinion, which is that 15 years since quitting is not a good eligibility criteria. People beyond 15 years, you quit 15 years ago, you continue to have risk of lung cancer at 20 years, 25 years, even at 30 years. So this criteria you need to interpret, I think, with caution, because people who quit longer ago retain the risk of lung cancer and should be screened. But what I'm reviewing is just the criteria by which the insurance company, Medicaid, Medicare, have to provide for free testing every year. Now, as Jackie mentioned, the task force made no mention of asbestos or radon or family history of lung cancer or a history of COPD or a history of pulmonary fibrosis. Those are all lung cancer risk factors. And so when you think about your risk, the friends of your risk of your family, your friends, your coworkers, you should also think not just about age and smoking, but you need to think about other exposures. Obviously, especially asbestos exposure going back in time, but also other occupation environmental exposures and family history or other diseases as well. Let me just say also, that the asbestos-related lung cancer risk, unlike smoking, it does not go down in time. It goes up in time. So normally when you're exposed to asbestos, you begin age 20, your risk for lung cancer, for the most part, doesn't kick in until you're 45 or 50 or 60, and then goes up in time. Unlike cigarette smoking, when you stop smoking, your risk goes down in time. So I thought that you should know about that. Now, that's the good news, an expanded group who can have this life-saving procedure, low-dose CT. But here's the bad news. Only 14% of people who are eligible for lung cancer screening every year actually do it. So for every 7 people who meet the traditional criteria of age and smoking, out of every 7 people, only 1 of them actually gets low-dose CT scanned in the past 12 months. It was introduced 2013 and officially sanctioned by the government in 2013. It's been going up very slowly since 2013. 8 years later, we're about 14%. But that means that the vast majority of people who could benefit from this procedure are not getting this procedure. And, it's sort of like the COVID and the vaccine. I mean, we can do it. It's in hand. And whereas we've got 70% of people who are vaccinated in the country, at least adults, we've got 14% of people who should be getting lung cancer screening at present. And so that means that this year, there will be 12 million people in this country who are eligible for lung cancer screening who will not be screened. And this is enormously frustrating. Now, it's not for lack of CT facilities in the country. I have a map of New York City and the 58 different radiology facilities, Mount Sinai, but Northwell and other places, I must say. 58 facilities where we, Andrea, Jackie, and I who live in New York can get screened. But I also have a nice little picture of the screening center in San Marcos, Texas, the ARA radiology facility. That's where Dr. Bonthornton lives. Now, I'm not suggesting that Celeste have this scan. What I'm saying is in San Marcos, Texas, there is a scanning facility that does low-dose CT. And I also have a little picture of Cabinet Peaks Medical Center. I think Cabinet Peaks Medical Center probably only means something to one person on this call. I think it's BradBlack, because that's in Libby, Montana, is where you can get your low-dose CT scan. There are over 4,300 facilities recognized by the American College of Radiology in the country that do low-dose CT scan. It is available. So that is not a reason why people are not getting scanned. We have now more people eligible. We have expert facilities throughout the country, and we have increasing reimbursement of low-dose CT scan. So what's the problem? I think the problem is that people don't know about this. And the problem is they're not educated. And the problem is they're not motivated. And some people are afraid because they consider lung cancer a death sentence. And actually, the early detection of lung cancer, what we find, what Andrea sees when she does surgery on these patients are very small, usually half-inch to maybe 1-inch small lung cancers that have not spread, that are removable through a scope. And Andrea can tell you more about that. But it's eminently resectable by surgery. And most of those people don't need radiation or chemotherapy afterwards. So people don't have that knowledge about what early lung cancer is, because they know, as we know from our own personal experience, friends, family, coworkers, of how many people get lung cancer and how many people die from lung cancer, that we equate lung cancer with a death sentence. It is not a death sentence if people participate in early detection. And so my plea, my frustration is that how do we increase the knowledge? How do we increase people's understanding of what lung cancer can be if detected early? And how do we motivate people to be screened for lung cancer?